Welcome, everyone, back to our series on non-interpretive skills in radiology. The topic today is contrast media. And I have a guest with me today, my cherished colleague, Matt Zygmunt. Do you want to introduce yourself, Matt?
Yeah. Hey, Nadia. Thanks for having me. I'm a neuroradiologist. I've been chairing our CT quality and safety committee for our physician group practice now for, 14 years.
Wow. Yeah.
I have written our current version of our policies around how we handle contrast reactions and all things safety related for contrast, mostly in CT, but I'm also a chief of service at one of our hospitals. So I have good insight into our MRI contrast handling as well.
Okay, great. There's ionic or non-ionic contrast, and then monomeric and dimeric. And then we also talk about the osmolality versus osmolarity. You have any understanding of these terms at all?
Yeah. And I think it's pretty simple, right? Because at least for our practice, we use pretty much one agent exclusively, and that's iohexol. And that's a low osmolarity agent. It's non-ionic, and it seems to have the best safety profile as far as we know. And on occasion, we'll use Catamol as well, but it's just not our standard formulary. And we use the 350 concentration of iohexol almost exclusively. It used to be that we would split protocols between 350 and 300, and it just became too hard to stock 300 as well. So we adjust all of our dose, all of our injections for 350.
Okay, great.
But yeah, in terms of practical knowledge, I think it's just to know that most of the safety conversations that we're having around CT contrast.
I think the ionic features and the osmolality play a role when we're talking about intra-arterial use. Some of these agents have an osmolality that is similar to the arterial blood, so they're better suited for intra-arterial injections. And then for intramuscular and other stuff, there may be other preferred agents. But I agree, we use that same agent also for pediatric imaging.
I was just saying sometimes the neurointerventional teams will switch to ISOView just because it has a little bit of a different profile in terms of the concentration and the osmolality.
Yeah. I think we're more interested in the adverse reaction. They happen very rarely. Only 3% of patients have any kind of reaction. Most of these are mild. But when they happen and we're nearby and we have to help, we get flustered. So I think it's good to have a basic understanding. First of all, there's a differentiation between a physiologic and an allergic-like reaction. Can you talk a little bit about those two things, how they're different?
Yeah, that's a great question. In my mind, the allergic like reactions are what you typically think about when you think of some sort of allergy to an antigen, even though we know that there isn't an actual antibody response to the contrast molecule, it's just too small. Those types of allergic reactions go from the mild, where you may have hives, skin reactive changes, possibly some sort of reaction in your airway that gives you the scratchy throat sensation, or even something that's a little bit worse as you progress to a moderate or severe reaction where you get enough swelling that it actually causes airway compromise. The physiologic reactions, on the other hand, I think of as more of the cardiovascular response to the agent being injected. It can make you nauseous, can get flushing, that sensation of warmth that you prepare every patient for before an injection, and then any type of change in cardiovascular status, whether you get hypertension or a vasovagal response. But those are the types of things I think about with physiologic reaction.
Yeah, thank you. And we're really concerned if that physiologic reaction is severe, if you have a hypertensive crisis or pulmonary edema, cardiopulmonary arrest. That's really what we need to recognize, that is a severe physiologic and not an anaphylactic or allergic-like reaction. Yeah, I always wondered about this term allergic. And I think what we know is that these reactions are not Ig antibody mediated. That's why we don't call them allergic, but they are phenotypically similar to allergies, and that's why we say allergic-like.
Yeah, and they seem to have a histamine response, which is why the antihistamines are part of the pre-medication regimen for these patients who have had prior events.
Yeah. And then the other thing that's interesting is that allergies that typically you get sensitized. So you have a first exposure, and then with subsequent exposures, your allergy can get worse. But with the contrast reaction, this prior sensitization is not required. So you can have it even without ever having had any contrast. You can have this kind of allergic like reaction.
Yeah, and
Right.
I think that's an important point that everyone should keep in mind because I think physicians who are ordering contrast studies on patients who have had a prior reaction are more inclined to say, oh, their prior reaction was just hives. Maybe I can get away with just Benadryl. And they don't realize that the reaction could come back as more severe or they could be fine. But there's this hesitation to do our pre-medication regimen. And for our residents who are listening, we don't make that distinction, right? Either the patient gets pre-medicated for a prior mild or moderate reaction, or we categorize them as severe and we look for an alternative. But that pre-medication regimen must contain steroids. We don't just do Benadryl only. That's something that we don't do.
Okay. Since you're mentioning the pre-medication, we can talk about that a little bit. I think the regimens vary a little bit from one institution to another, but the main components are steroid and diphenhydramine or Benadryl.
Yeah.
And it can be given orally. I think typically starts at least 12 hours before the scan.
Yeah. And this is something that's been interesting with our group
Hmm.
recently because finding standardization with this has been difficult across a large organization. And one of the things that we've done to make it easy is we've built out an order set for the physicians in our hospitals. It's the same order set for everybody. It's available to everybody. And it allows you to pick the pre-medication regimen and it gives you all the options as prescribed by the ACR contrast manual. So we're in line with the contrast manual and it orders it least to most desirable with sort of guidance. So like a clinical decision support with the guidance for the physician. So they know exactly I'm doing a 13-hour prep. This is what's required. And they just click the buttons and the order comes across the way it should. I think the recent change is a more recent paper from Matt Davenport, which seemed to indicate that there was non-inferiority of the 5-hour prep when compared to the 13-hour prep. And the way this has impacted our practice is that the time sensitive patients more and more are getting a 5-hour prep. And that's really caused so much consternation in our organization, right? That this pressure for length of stay metrics, particularly in the ED, they don't want to wait for a 13-hour prep. They don't want to admit to the observation unit. They want to just go ahead and get the patient scanned and out of the hospital if the scan doesn't show anything that needs admission. So that's really where we are now. And, the more we use that, I really see us shifting towards a 5-hour prep that has 2 doses versus making the patient wait for a full 13-hour prep if that data holds up.
That's good. I hadn't heard about the 5-hour prep, but I knew that there was a rapid prep for, I guess, semi-emergent studies where you do IV cortisone instead of oral, and you still do the Benadryl 1 hour before the exam. I guess
Yeah.
super urgent, you just have to take your chances, right? If it's really needed, then you have to treat whatever possible reaction separately.
And that's really been our guidance. And so just so the residents listening know, if you're in our institution, that 5-hour prep is an option. It's at the bottom, so it's selectable. It does require them to have the 2 doses of steroids. So they get a dose, they wait 4 hours, they get a dose, and then the scan is scheduled within an hour of the second dose. And it includes the Benadryl as well. And we're seeing that the ED physicians in particular are trying to use this more and more. And my guidance to the residents are based on Davenport's data, there really shouldn't be any pushback here. You should feel okay with the 5-hour prep, especially if the prior response seems to have been mild or moderate. But to your point, I think we fail in that physician to physician communication sometimes where we need to just talk to the ED. And sometimes they're worried about one particular thing. And we could very easily start with a non-contrast scan. or start with a different modality to answer their question, make sure that there's no life threatening situation going on, and then decide, are we going to fully prep this patient? Do they really need contrast? Is there another direction we need to go? And that conversation isn't happening as much anymore. And I really encourage our teams, do the check-in, know who your doctor of the day is in the ED if you're covering the ED, and keep those lines of communication open. That's my advice for that. And then, of course, yes, emergent situations. Our policy is that if you have a patient with a severe prior reaction, we're not supposed to pre-medicate. They can if they want, but it's questionable whether or not that helps. Our requirement is that the clinical team come with the patient to the scanner and be ready to intubate that patient should they have a severe event that requires airway management. And that way the team is there and ready and available to respond should the patient go downhill quickly.
Yeah, I think that's great how you're managing that. I particularly like your order sets and for the providers. That's a really smart way of addressing it. Talking a little bit more about the premedication literature, I think there's been some confusion because there are some papers that were cited as saying that we don't know whether premedication is effective for more severe reactions simply because the data populations mostly had mild reactions. We don't have enough patients to be sure statistically that it's effective, but that shouldn't be misunderstood as pre-medication should not be used in those patients. I think it's particularly important for patients at risk for a moderate or severe reaction to try to address it with a pre-medication schema.
Yeah, and I think that's an important thing to keep in mind. Like a lot of this, we're making some loosely informed decisions to shape our practice across the entire enterprise. If somebody has had a prior reaction, we're going to recommend that they get pre-medicated. But in our policy, we draw the line between moderate and severe. And if that patient had a prior severe reaction, we prefer not to inject them again if we can avoid it, if there's another option. Sometimes there isn't. And I agree with you. You probably pre-medicate them for a matter of safety if you have time.
I wanted to talk a little bit about the risk factors for adverse reaction for CT contrast media, iodinated contrast. I think what's interesting is that although there is no sensitization, there is still a higher risk for contrast reaction if you previously reacted to the same contrast media or to the same class of contrast media. So if you had a prior reaction to iodinated contrast, then you're 5 times more likely to have another reaction with an iodinated contrast, regardless of the brand. And similarly for gadolinium, if you had a prior gadolinium reaction, then you're more likely. So that's interesting. The other big risk factors we talk about are existing allergies and asthma. And
Yeah, these things are in our screening form in its current version.
there's another population we need to pay attention to, although rarely it happens, but it can be that a patient has thyroid cancer or hypothyroidism and they're waiting to get radioactive iodine treatment. And for those patients, if we give them IV contrast in 4 to 6 weeks prior to that treatment, it can saturate their iodine levels and make that thyroid treatment ineffective. So that's just something to remember.
Oh, that's a good point. And I'm trying to remember, we streamlined the screening form recently, and I believe that's still in there with the number we called for nuclear medicine, just to make sure the patient is cleared for a scan.
Matt, besides the allergies, there's an issue with kidney injury. So this could be either in patients who already have chronic kidney disease or there could be acute kidney injury. Can you talk a little bit more about that?
Yeah, absolutely. That's really something that in our current policy, we spend a lot of attention to. I think it's important to understand some of the history. We had a 3-step process where patients were put into 3 buckets. One was okay for contrast, one was borderline, and the techs were hydrating the patients before giving contrast. And then we had a threshold where patients were thought to be at risk, right? So we had a certain serum creatinine level where we said, look, it's probably too high. We don't want to further damage the kidneys. We need to look for an alternative. And I think when I first started practice, there was a sentiment in the physician practice that the kidneys really needed to be protected. And the pendulum has totally swung on this. And what really started the pivot was when the Mayo group and Davenport's group at Michigan put out simultaneously those two large cohort studies that did the propensity score matching. And they showed that in the group that did not receive contrast and the groups that did receive contrast that were clinically matched as cohorts, the risk of a post-scan kidney injury was very similar. With the committee that I'm on now, the view is that, okay, we're still following ACR guidance in that there is a cutoff, right? This third tier that both of those papers showed, where we think there may be a higher risk of kidney injury after contrast. And so we use that stratification to decide. But in general, for us, in our current physician group, we tend to think that the contrast is safe, that you can give contrast. And even if a patient is beyond the threshold for where you think they may be at risk, the follow-up analysis, especially that Matt Davenport did, seemed to indicate that those patients, even if they did have a bump in renal function after contrast, the vast majority of them returned to their baseline. And so we're now operating under the assumption that the agent we use, this low osmolar non-ionic agent, has a good safety profile. And we don't necessarily need to be screening for contrast. And so our policy reflects that. We have carve-outs where we don't even screen creatinine, especially healthy walkie-talkie outpatients. If they don't trigger any of our flags, we don't do a point of care. That speeds up the process. And to be honest, in the 14 years of doing this, I think I've had one or a safety event, right? Documented safety event where the concern for kidney injury was raised.
We're taking a break here. Please turn to our next podcast with Matt Zygmunt to learn more.